Good morning, everybody. This is the data integration work group. For those of you who are joining us again after phase one, hi Carl, hi everybody. Many of you are joining us again for phase two, so it's great to see you all again. The last time that we got together was, I think, between June and December-ish of 2021. So welcome back. My name is Jeff Vanderplug. I think I know pretty much everybody on the call. We have a couple of co-facilitators that I'll let introduce themselves in a moment. Elise Kelly from CHGI is also helping to support our meeting. If you don't mind, as we get started, if you could drop your name and organization into the chat box by way of introduction, that will save us a little bit of time. And also, you probably already saw that this meeting is being recorded, and so we'll make that recording available on the website in case you need to refer back to it at any point. So just a quick introduction. Again, we met from June to December. We're going to refer to that as phase one, and we'll do a recap of phase one's data integration workgroup activities in just a little while. But I think I wanted to set the table a little bit for this group. Our sense of this is that we want to get your best thinking about implementation of phase one recommendations. And so when we met last time, all the way through December, we ended up with a good set of recommendations. We have a sense from this group about what direction we wanted to take in this area of data integration. The question now is really getting your best thinking about how to implement those recommendations. We're going to focus on a couple of key areas. So it's going to be a lot of creativity. I really encourage you to take yourself off mute and let us know what you're thinking. We do have an agenda and a structure for today's discussion, but we really do want to get your creativity going here. So with that, I will turn it over to Beresford, and he's going to walk us through today's agenda, and then we will go from there. Thanks, everyone.
Good morning, everyone. Beresford Wilson. Currently, I am the Executive Director of the statewide multicultural family support organization known as FAVOR. And as I said earlier when we first came on, I'm glad to see this work get its legs back under it, and we get moving in a forward-moving direction. What we're going to do today, and I don't know if we're sharing the agenda or not, but what it looks like today is our work group goals. Goal one is to finalize and onboard state agencies, and I'm glad to see how many state agencies are represented here today. Thank you for sharing. And hold on.
Can you see the agenda okay, Beresford? Do you want me to scroll down?
I can. I had my own, and then
Okay.
when we shared it, it overtook mine.
Sorry.
That's fine. That's fine. I'm going to finalize now onboard state agencies, and I believe there are 12 of you all who are here today and represented. And we're onboarding you all into the P20 Win. Also, another goal is to finalize the Children's Behavioral Health Dashboard and Implementation Plan to support ongoing systems improvement and reduction of health disparities. And if you go to Plan for Children, you'll see the final draft of the plan. Also, we have talked about doing this work in five months. I think that's going to take some discussion also, but the cadence and the plan is to have monthly meetings. That might also change. There's been conversation of quarterly meetings, but I think that's something that also we have to have dialogue about. There are materials. There's a PowerPoint presentation, which you will see today on the proposed dashboard. Our meeting objectives are to confirm phase two goals, review proposed dashboard, and review proposed data integration project. what our agenda looks like today, as far as who you will hear talking. You'll hear Scott Gall from OPM reviewing phase 1 recommendations, also phase 2 work group goals. Jeff will come back on and talk about the proposed dashboard. And also the data integration pilot or / project, whatever we're going to end up calling it. I'll wrap up today and talk about next steps, and then we'll adjourn. And I will pass it on to Scott Gall to talk about review of the phase 1 recommendations. Scott?
Thanks, Bear. Sure. I don't know if, okay. I will pause momentarily while get the slides. So this is, I think, as Jeff said at the beginning, and I think Beresford continued, hopefully this is a meeting where there's some good discussion as it is the kickoff for phase 2. This is the one part where we're going to take a look back and a trip down memory lane for phase 1. I believe most of the people who are in today's meeting were involved in phase 1, but if you weren't, or somehow you have forgotten some aspects of it, this is a good time to recap, just make sure we're all sort of at the same point. And if there's questions about anything that came out of that first phase, it's a good time to bring it up. But this is, we're trying to sort of get back to everyone sort of level setted for the conclusion of the first phase so that we can begin a next phase of this, and to do that with the active participation of everyone in today's meeting. So I'll recap the general framework for phase 1 and some of the recommendations that came out, and I will hand it over to my colleague, Manisha, also from OPM, to talk about some of the framework for phase 2 in a second. So for phase 1, I think this group particularly obviously is focused on data integration. It looked at the ways in which for behavioral health, the ability to integrate data would be helpful to either develop sort of a system-wide view to understand the impact on individuals who might be involved with multiple different systems. And so I think we heard about why it is important to be able to look at data across multiple systems for a variety of reasons. We talked about the ability of the state to do that in different forms through different kinds of efforts. We focused a lot on P20 Win, which is an effort that we can talk about in a little more detail. And then started to look at, if we were able to integrate data across different state systems, what would we want to be able to learn from that? What are the actual things that you'd start looking at to measure, the indicators, the types of things that would tell us about the health of the individuals involved in the behavioral health system and the system as a whole. And so that work group produced a set of recommendations that went back to the Children's Behavioral Health Plan Implementation Advisory Board. And those recommendations are on the next slide with a little more detail. These are in the report, which I believe everyone has in the agenda here. I will just sort of, again, try and recap and summarize these a little bit. The first couple of recommendations are about what I would call like the system, the ways in which we're able to integrate data across different agencies. We're leaning a lot on P20 Win, which is an effort that provides the legal and governance framework to link administrative data across different agencies. The next kind of set of 3 and 4 recommendations looked at the actual things that, 3 and 4 looked at the actual things that you'd want to measure, the actual indicators. What are the things that tell us about how the behavioral health system is functioning, the impact on individuals as they navigate it, what the pain points are in that system. How could we make that into a tangible thing that we would get some actual data back from, so that people could understand, how the behavioral health system is functioning, and sort of work to use that as a way to work to improve it. And then last but not least, is an important set of recommendations under recommendation 5 that are often not the ones that are the most interesting to focus on, but are really important to make sure that we are collecting data, improving data quality in a way that if we are able to link and link these data sets across different systems, that it will actually tell us something, that we don't have huge gaps in the data, that the data quality is there. So this is the kind of thing that is not necessarily everyone's favorite topic to discuss, but it's important to make sure that we've got high quality data if we are able to link it, pull it together, and use it to develop some insights. So this is, again, kind of a summary of the first phase of this. And I will flip it over to Manisha in a second to start talking about phase 2, unless anyone has questions or anything you want to go back to phase 1. Again, I know a lot of people were involved in it already. This is sort of going over what you already talked about. But it's been a little while. If folks had questions on anything, this is a good time to ask. I know this was presented back to the Behavioral Health Implementation Advisory Board. Jeff did a presentation to the Executive Board for P20 Win, which is the leadership of some of the agencies that have agreed to this framework for linking their data together. And that was a interesting and productive discussion with that group too. So we're hopefully taking these recommendations, circulating them, and making sure that there's support from the agencies to move forward on these as well. Any questions? All right.
I guess we can move on to the next slide. So hi, everyone. My name is Manisha. I'm from OPM. I'm part of Scott's group. So building upon the recommendations that Scott just reviewed, we have the following 2 proposed goals to consider for the second phase of this work. We can consider what the work group will look like, how long it will continue. This is all up for discussion. So the first was to finalize onboarding state agencies to the P20 Win system. Many agencies that are involved in children's behavioral health are actually already part of P20 Win. So this would be continuing discussions for the remaining agencies and bringing them on board. And this is work already underway within OPM that we're really focused on. And then also as part of that is to run a data integration project through P20 Win. We were thinking of focusing on children involved in multiple systems, trying to understand the patterns of service utilization, as well as short and long-term outcomes. And then a second broader goal for this group to consider is to develop the children's behavioral data dashboard. And we anticipate it will be first populated with current indicators that are available in data. And then as part of this group, we would also look towards implementing continuous improvement to that dashboard into the system overall, with a focus on a reduction in health disparities. And that overall, over time, as we get more data and as the system improves, we can build upon that dashboard and continue to improve it. So these are broad goals outlined for this group. I'm going to kick it over to Jeff to kind of walk you through what we've been thinking, and I'd love then to get feedback from all of you.
All right, thanks, Misha. So let me just pause again for a minute just to get people's thoughts or questions, because we just went through like 5 or 6 months of work in about 10 minutes. And what I'd like to point out is that we had 5 recommendations from phase 1. Recommendation 5 had 3 parts, and you can see on the screen here right now that we're choosing to focus really on 2 major recommendations or goal areas from those 5 in phase 1. So I just want to get people's thoughts about that direction, and any questions that you have or comments that you have before we kind of start to dig in a little bit to the first of those.
Jeff, I guess my comment is when you presented phase 1 to the oversight board, what was the reaction, comments? Did they kind of weigh in on guiding relating to phase 2 goals?
Yeah, I'll start and then I'll kick it to Scott, because I think he'll have some insights into how the group responded to it. But overall, I thought it was a good meeting. I'm not sure that group, and we talked about this going into it, that I'm not sure that group had really fully contemplated a behavioral health related request. So they were kind of thinking through that. The participants in that group, are looking at it from the standpoint of sort of like the technical requirements of the request, the data security requirements of the request. And so we kind of worked through some of those questions and thought, and it was really a lot of education about what for me at least, telling them what we had in mind as a system, what we thought we needed to start to look at for children who are involved in behavioral health. And then what we were receiving back from them, were sort of sorting through the technicalities of it. But Scott probably has additional thoughts because I know he knows that group really well, and maybe even had some follow-up discussions with them after the presentation.
Yeah, just add briefly to that, but I think Kathy, you're asking about the implementation advisory board too. Jeff, I think, has done multiple presentations of this.
Yeah,
And
that's
so what Jeff's referring to is presenting to the P20 Win Executive Board, which is the agency leadership for the 10 agencies that participated in it, which includes some behavioral health agencies, but also education and workforce agencies. And so, behavioral health is frankly just not the thing that some of those agencies work on day to day. So it was, like Jeff saying, a little bit unfamiliar, but interesting discussion. And to me, it generated like healthy, new ideas. People started talking about, well, could we look at the educational outcomes for people in the behavioral health system? Do they, graduate on time? Do they attend college? Do they find, work in Connecticut? And so it's a good way of getting sort of like cross-pollination, is a new idea, but we've got, I think, some agencies that are, interested in sort of like the long-term push for getting some of these kinds of things worked on. So I was generally supportive. You can watch the video of it. I'll send it afterwards. But I think, I don't know, Jeff, if you want to cover the implementation advisory board.
Yeah, thank you for buying me 90 seconds of time there, because I was trying to remember exactly what I did hear back from the advisory board, and I am racking my brain and can't really, I know that some people on this call were part of that meeting. I mean, my general recollection is that I thought that the reception of it was good. We were probably reviewing the recommendations from the data integration group together with the recommendations of every other group that we were running at that time, which is maybe why I can't remember the details of how they responded to this particular set of recommendations. But I think that the reception of it was positive. I think they felt like we had achieved the goals we set out to achieve with the phase one activities. And it looks like maybe Carl's going to bail me out here a little more. Thanks, Carl.
My pleasure, Jeff. Thanks for having this meeting and continuing with phase two. I happen to be one of the tri-chairs at present of the Connecticut Children's Behavioral Health Plan Implementation Advisory Board. And yes, we need an acronym. And so what happened on January 24th is exactly, what Jeff described. It's the three work groups that were formed and worked, through late last year on their various challenges, all made presentations at this January 24th meeting. I must admit that, while we were thrilled with the outcomes in the various work groups and are very grateful to every member of each of the three, in fact, 4 work groups that we created over the course of this work, our attention was a bit distracted by the intense and welcome attention being paid to children's behavioral health at the highest levels of the executive branch, in the judicial branch, and now in the legislative branch. And in fact, trying to make sure we built in some of the principles and recommendations that came out of your work and the work of the other groups into gubernatorial proposals, agency proposals, and legislative proposals, and ultimately, hopefully, to become the law of the land to help us, continue this work. And I'm happy to say that there are several pieces of legislation, pending before the General Assembly as they work through their regular session that we hope will help bolster these efforts. I'm certainly not aware of any bill that would impede us, which I think is great news. So now it's just the challenge of figuring out how we all move forward together. And in fact, as I sit here, I know there are at least 2 bills that would impact the membership of the advisory board itself, and perhaps alter how the children's behavioral health system is overseen and advised by the state and the community partners and providers and recipients of care. So the world may look a little different come May 4th when the legislative session adjourns. And I think we're all sort of taking a pause and trying to figure out what that world's going to look like in terms of these new laws and dedicated spending. But I feel quite confident that this work will proceed apace with the full support of the advisory board and frankly, the support of all the agencies that are represented here today, and perhaps a few that aren't. So thank you, Jeff. I thought it was a great great outcome and a great start. I wish I could offer you a clearer future, but that's the latest from the advisory board. Thank you, Jeff.
Yeah, thank you, Carl. I'll just add quickly and then I'll kick it over to Chris, who's got his hand up. But one thing to think about one of the recommendations that we've seen circulating is rethinking, as Carl mentioned, what does the membership of the Behavioral Health Plan Advisory Board going to look like? And I think embedded within that is just general discussion around what children's behavioral health governance structure will look like over time. So one way to think about the recommendations and activities of this work group in phase 2 is to think about how the data-oriented elements of those governance proposals might be informed by this work group's activities. So as we think about decision making and looking at data and helping that to inform how decisions are made about children's behavioral health system and services, that's one way that this work group could be used. So let me turn it over to Chris.
Well, I just had a clarifying question about goal 2. I think one of the things that we have found is that developing dashboards is a primary activity, but I think that part of the implementation plan is a well-defined intervention plan as well. Is how are you going to use the dashboard to actually make the system improvements and reduction of health disparities? So I just wanted to make sure that we're thinking that the implementation plan is inclusive of what an intervention would look like in using the data.
Yeah, it's an excellent point. And as we get into the next slide, maybe this is a good transition point to go to the next slide. A project in P20 Win. What I have in my own slide notes here is this should not be a research project. We should be looking to structure a project request to P20 Win that has some implications for service delivery, as Chris is suggesting. So it's not just, can we merge some data and ask some interesting questions and then look at the answer over time. It really, the point of all this is to make sure that it has implications for service delivery, and that's part of the planning from the outset. And I hope I've captured your point accurately, Chris. So let's kind of transition into that conversation. Everything that you see on this slide is just an example. All right, this is not the project. These are just some ways to kind of get you thinking about the overall question, which is, what do we really need to know about children with behavioral health needs who are part of the behavioral health system? What do we want to know about them in the short term, particularly cross-system types of questions? That's why you see things here about DCF involvement and juvenile justice involvement and chronic absenteeism, because really P20 Win is best utilized as a way to look at questions across systems. So as you look at these different questions and examples, let's try to structure or at least get some ideas on the table about what we want to know about children with behavioral health needs across systems in the short term or in the long term. And let's also keep in mind Chris's point about how that informs, new service delivery goals that we might develop from that information. So take a moment, look at this, and then when you're ready to ask a question or make a comment, just go ahead and come off of mute.
Yeah, so one thing that I always like to see, which I don't see too much of, is information on single family households, especially with the father or the mother as primary, because we know that there are parenting differences and they impact family health in general. And I don't really think anybody really does a good job of capturing that.
All right, thanks, Mike.
Yeah.
Other Other thoughts or questions?
I wonder for the group, if this information and this data would help in your service provision, like what kind of, hopefully this is information that you would be able to then take and kind of maybe consider modifications. So maybe not directly service, like changes in service delivery, but just information that will help you in your work. And hopefully these questions that we've listed here and generated these subgroups that we're hoping to understand the overlap between them makes sense to this group.
I think one of the things that may be missing, and as one of the primary goals for the work group, is to identify the health disparities that do exist among the different service systems and also services. I think that definitely needs to be one of the short-term questions of identifying what those health disparities are.
Yeah, great point. So that could be disparities in access to services, disparities in quality of services delivered, disparities in outcome. It definitely needs to be incorporated into all those questions. Agree.
Jeff, what about kids that are DDS involved?
Okay, tell me more. Well, as thinking about just that, as you were to, if you were to frame this as a question to put to P20 Win, Sarah, what would you want to know? There we go. Right.
Well, boy, I'm not, I'm just re-entering this group, so I'm a little self-conscious. Mickey Kramer, who recently retired, was covering this group, so I'm a little at sea, Jeff.
That's all right. That's all right. We'll think it out. We'll think it through together.
Just looking at the concentric circles here, right, and identifying children who are involved with different key service systems, right, DCF, juvenile justice, and we know, that kids who is there a question that we can frame? I guess really it's a question for you first. Is there a question we can frame around to tell us how the behavioral health needs and are met and what the outcomes are for children who are also identified as eligible for DDS?
Yeah, I think that is an example. That is something that could be done. And what it gets me thinking about, at least, is really like a fundamental question that I think was tackled, and check me if I'm wrong here, Scott, Manisha, Chris, with the 500 Familiar Faces project. I think one of the more insightful findings that came out of that was just understanding the extent to which individuals were involved in multiple systems. So if you start with a group of children who are being served in a behavioral health system, and then you also look to see, well, of this group, how many are also involved in the intellectual developmental disability system, or the juvenile justice system, or the child welfare system. So that could be just a very fundamental question we could ask through a P20 project to understand a little bit more about multiple system involvement. And I invite Chris or anybody else really to kind of like dig deeper into that to see if that's worthwhile.
I think one of the ways like the service providers can use this information is really to start benchmarking us against this data, state data. And sometimes that can get tricky if we are comparing apples to oranges. So I don't know whether we would have filters such as urban or rural population, so that as we are looking at our internal data and seeing how we are doing compared to the state, and if there is a way we can make it better. But sometimes it gets tricky, as I said, when we are not comparing the right things. So I don't know whether we would have an opportunity to do filters for urban or rural segments.
Okay, so thank you for that. So essentially a question, I'm assuming, around outcomes, right? So if you were looking at outcomes by provider with some adjustment based on various factors. How do providers compare and contrast against one another in terms of outcomes with particular populations? Do I have that right? Okay,
Yes.
great, thank you. Yeah, that's another really, really good question. Other thoughts?
Jeff, I just want to come back to the school piece real quick. So the children identified as having chronic absenteeism is already part of the framework, right? That you have here. And that data would come from SDE?
Yeah, I think SDE, I think through their EdSite data has, they do have data on rates of chronic absenteeism. And it'd be a good question for SDE actually, whether they have that at the individual child level that would allow you to merge data points across systems, but that's the general idea. Yeah, that would come from SDE.
I wonder what else might be available from them that could be disaggregated by the individual child and merged with this, right? I don't know the answer to that beyond absenteeism, but I would be interested to know that. And I think just from as we think about what is the data we need to know to get sort of evaluate, what factors are supporting the efficacy of service delivery and the outcomes, right? That school piece is so important, right? And we know that kids, I shouldn't say we may know, I assume that kids who are chronic users or have chronic need also have chronic school needs too, almost always, and are almost always underperforming in school, sometimes by a lot. So are there other things we can know about them in terms of their service needs at school or even their grade level performance at school? I don't know if that's doable, right? But like, for example, in the deep end of our JJ system, right, we know that many children are multiple or have been multiple service system involved and are also performing many years below grade level with long histories of chronic absenteeism. So that like most of the kids, for example, at MYI are assessed at performing at the 5th grade level educationally. And without addressing that, right, because there's such a strong link between unmet educational needs and behavioral disorders, without addressing that sort of systematically, we're missing a really key piece.
Yeah, good point. And my guess is that there's a lot more than just chronic absenteeism that you could extract from SDE's educational data that you could incorporate in there. I wish I could rattle off exactly what those things are, but yeah, it's definitely worth looking into. And if there's anybody from the education system who wants to comment on that, that'd be great. Scott?
I am not from the education system, but I'm going to comment on one aspect of it. I mean, I think is good for like a phase 2 discussion. So there's a double-edged sword for writing things down, which is what Jeff has done on this slide, because it's good to have something that's a starting point, so that people are not working from a blank slate. But the challenge is that you don't want to get anchored on just what's written here. And I think to Sarah's comment, are there things that you would want to look at other than chronic absenteeism? Maybe. I'm not a behavioral health expert. Obviously, that's what I think the focus for this group could be, understanding what are the things that you really want to understand from which systems. Maybe education is not important, maybe it is, and having the group sort of determine that. So these, I think, are hypotheses and examples. What you could go back to, what we have built up, I think, with a lot of the executive branch agencies, which is not, again, what people are necessarily excited about, but there's a data dictionary for all of these agencies. Maybe we're missing one in here, but we have a dictionary. What do these agencies collect? What do they have available that they just collect as a baseline? What is the kind of thing that they make available for requests where you can link or match it with other agencies' data? What's the frequency with that? Is this something you're getting on a daily basis or something on a monthly or in just each academic year? So chronic absenteeism is here. It's something that State Department of Education does collect and is used in a lot of analyses. There's other things they also collect that might be good examples to look at. I think there's also limitations there. I know there's the comment earlier about single parent households. That's a question I don't know the answer to, but it's just a sort of yes or no question, like for example, to use education, does education track whether it's a single parent household or not? I don't know the answer to that. If they don't track it, then we can't use that in this kind of project. But we've got a good listing in a data dictionary for most parts of this system of what is collected, and that's a good baseline. So if something's collected and the agency allows that to be used for these kinds of requests through the sort of framework that's available, then I think it's a good topic for discussion. But having the group discuss what do you really want to measure, like these are, I think as Jeff had said, these are examples and a starting point, but people should take and modify it and see what's going to make it useful for the work you're doing.
Thank you, Scott. And let me just ask a very quick follow-up, and then there are a number of hands up. But Scott, back to you. Did I hear you say that through this project, through P20 Win, you have a pretty good inventory of the data elements that are collected by all, or most of the child serving systems that are part of the P20 Win?
Pretty good is a very good description of it. Yeah, so it's a work in progress. But this is the group will help improve that by saying, I wish we knew, I don't understand this, or we should have that filled in. So,
but that's actually a helpful bit of information for the group to know that it's not like we would have to go inventory all the data elements that are currently collected. We would have at least a good starting point to understand where we could go with it. And Kathy is suggesting that reviewing a data dictionary may help us develop some additional focus. And also, I just want to lift up that Elise reminded us that in the educational realm, exclusionary discipline has been another area where this group in phase 1 said we could do some additional analyses looking at the impact of exclusionary discipline or how that factors in. So let me turn it over to Chris, and then Mike, and then Maureen. Chris?
Just a real quick thought and a follow-up from Sarah's point is it made me think of there's a difference between behavioral health needs and behavioral health service utilization. And I think that getting the short-term question of what are the behavioral health needs and the what you would expect and what actually is happening within the service system based upon actual service utilization. So I think getting at the difference between those two can really tell a lot, and stratify it by demographics to be able to understand what the differences are and where the gaps are as well. So I think not only is the pattern of service utilization, but I think also the difference with behavioral health needs.
Yeah, great point. And we'll see if we have time, and I think we will have some time on the next couple of slides to look at the system indicator framework that we developed in phase 1. And Chris, if you recall, one of the things that we identified that we wanted to know and look at as a system was having a better understanding of prevalence or need. We can see kids that use services, and we can see that in the Medicaid data and elsewhere, but that doesn't necessarily tell us what the need is out there in the community. So it's important to understand how those two map to each other. Let's go to Mike, and then we'll go to Maureen.
Yeah, so I'm just thinking that not everybody reaches like state agencies, or the kid have a life before school. So there's a lot of early childhood programs. How about hospitals and pediatricians? That is there something they can provide? Daycare centers. I'm not sure what kind of things they keep track of, or if they do, but things like that before they get involved with state.
Yeah, good, excellent point. I think there's a tendency, I think, in projects like this to focus on kids who are already pretty deeply involved in the system. And I think to your point, identifying early risk and early needs and how those needs are addressed, and then how that translates to long-term outcomes, I think is an important thing to consider. Thanks for that. Maureen?
Thank you. To further what both Mike and Chris are talking about, I think primary care providers have data that would be valuable around, in particular, ACEs scoring among young children. That data would give a framework to explore needs, behavioral health needs going forward. And I'm always talking about data around whether a child is biological, adopted, or in a blended family. Not all children who are adopted touch the DCF system. Some are adopted internationally and privately. And those children need to be identified, I think, early in some sort of data collection as having, early exposure to loss of biological parent or early childhood trauma, certainly from another country. And that would suggest future behavioral health, mental health needs. And that certainly would be good data for advocacy groups around policy reforms.
Okay, thanks. Let me, Maureen, real quick, as a follow-up on the ACEs as an indicator of prevalence, do you have I know that there are some small projects where people are collecting ACEs. Are you aware of any projects going on statewide where we're getting like a real wide look at prevalence of ACEs?
So I believe two things. I think through the Clifford Beers programming and their new trauma initiative, and the grant that they got, there is something that they're working to roll out around ACEs. Dr. Alice Forster has been involved in that quite a bit. But I also know through the Medical Home Initiative, there has been a push for all pediatricians to administer the ACEs scanning early on. And so I would think another agency might have some information on how far they've gone on implementation of all pediatrician offices collecting this data.
Thank you. Elizabeth, do you want to talk about PACEs?
Well, I think it would just be good to coordinate with them to look at where there are opportunities to intersect the data. I'm not sure how much at an individual level as much as a system level, but I do think that is where we can connect the two. I think that would be very helpful.
Great. Okay.
And probably we should have representation because that started before this work group. I mean, that started after probably this work group got formed. It might make sense to have somebody from the PACES Data Action Grant attend this group regularly.
Right. Yeah, and as you mentioned, that's the leads on that are UConn and OEC.
Yep.
So that's a good suggestion. And Scott, is OEC a P20 Win partner?
Yes, and actually Commissioner Bai chairs the board. So
yeah, so I think that definitely gives you a like a mechanism to get that data integrated in some way. All right. Any other comments or questions before we move on? We wanted to spend a little bit of time on the system level dashboard that we developed in our last phase. Any other questions before we move there? Okay, let's go ahead and flip to the next slide. So as those of you who were part of this phase one group recall that we kind of started with P20 Win and 500 familiar faces for the first couple of meetings. And then we transitioned to talking about a behavioral health system dashboard. And the main focus here was what high level indicators and information would we want to know to understand whether the behavioral health system was functioning and working the way that we wanted it to. And that was driven by a desire for a higher degree of accountability to the public of how the behavioral health system is working. There was a lot of discussion about looking at bed availability as part of that being something important to monitor, identifying barriers to throughput, assessing needs over time, and then really tracking those system level outcomes over time. So that was the backdrop for that question. If we go to the next slide, Elise, you can see before we get into the right side of the slide on systems questions, I do think it's important to point out the left side of the slide. First of all, and this gets to Chris's point earlier, looking at all of the data that we have from a standpoint of health equity whenever possible. So disaggregating by race, ethnicity, income, and a variety of other factors to make sure that we're looking at this from an equity lens. But I thought that one of the really important things that came out of our discussion in phase one was just having a sense of the categories, the major categories that we wanted to monitor over time. So the first being having a better understanding, not just of who's receiving services, but what the true need is in the community. So that's where we started to talk about prevalence and identification of needs. From there, we talked about access in the system, and you can think about access in a lot of different ways. A couple of examples on the right include whether there's sufficient insurance coverage of services and availability of services and wait lists for services. Those are all things that we talked about in the last meeting. Then there were the services themselves, what services are available in the system, what does utilization look like. We also, at that time, if you recall, we're really starting to hear a lot more about the workforce crisis. And now I think we have a much better understanding about the true nature of the workforce crisis that we're facing coming out of the pandemic. And it's going to be an ongoing challenge. There's going to be an investment or a desire to invest in services in our state. But if we don't have the workforce to actually deliver those services, then we're missing a pretty important part of the puzzle. So we wanted to make sure that we had some indicators to understand what the condition of our workforce was in a lot of different ways. And then we also identified costs as being important. And particularly if we're investing in certain services, are we experiencing reduction in costs in other parts of the system? And then finally, what do outcomes look like? And at this level, we were not necessarily looking at the outcomes for individual programs or services, but really at the highest level, are we seeing changes in risk? Are we seeing changes in system level utilization of inpatient hospitalization or behavioral health emergency department visits, for example? That's really the level of population outcomes that we were contemplating in that work group. And then again, looking at all this from the standpoint of health equity and racial justice whenever we have those data available to us. Let's flip to the next slide.
Jeff, just real quick.
Sure.
When you talk about disparities, are we also thinking about disaggregating by geographic region where kids live? Is that something that is doable?
Yeah, I think that is doable. I think, again, to the extent that you have the data available and you can break it out by geography. Well, but if you can't, I think that becomes a data development agenda item. If we can't understand how services, for example, are distributed in all parts of the regions of the state, then we need to develop the capacity in our data monitoring systems to be able to answer that question.
Right, because I'm just thinking the access piece is as much about coverage and availability, right? Existence of the service, coverage for the service, and then the actual physical access to the service. Right. So it's not like an hour away for people, or where transportation is not otherwise a barrier somehow, which we know it is often.
Okay. So yeah, we can, if it's not reflected in our list of access indicators, Sarah, we can add that and make sure that that's considered also in our access category. So phase one, we had a much longer list of indicators. What we tried to do was narrow down to what we thought might be the most useful indicators in each one of those categories. So that's what you're looking at right now. I'm not going to read these all to you, but maybe we can, I'll give you a couple of minutes to look this over. We have about 9 minutes left in our meeting time. Take a quick look at this. What jumps off the page to you? What questions does it raise? And then I think ultimately what I want this group to understand is that we're going to have to move this proposed set of dashboard indicators also towards implementation. So it raises the question about who's gathering this information together. These are coming from disparate data sources. Who's going to pull all this information together? Who is our audience? Who are we going to share that information with? And at what frequency? So those are some questions that we're thinking through right now as well. But let me just leave this slide up here. And if you have a question or comment, just come on off of mute.
Hi, Jeff. I just wanted to introduce myself. I'm new to the group, and I'm with the CT Data and the Hartford Data Collaborative, which is more of a municipal data integration project. And so part of this, I think, would be helpful for us as we can think through ways in which, to your point too, Sarah, about local impact, like where services are specifically for local city leaders and city programs. This is an area that Hartford city departments would like to get more access into these indicators at the city level. So as we build this, if there's a way to factor that in, how municipalities could be a part of this integration project, that would be really helpful. I also had a question too, and I'm sorry because I'm new. I know equity's been raised a lot. We're also bringing community voice into our data integration project and bringing in some youth researchers. Just thoughts as we develop these indicators, kind of what the communities of persons with lived experience think about them, what they're, I don't know how that sort of, this is more about just understanding kind of where that comes into this planning effort as a data owners.
Yeah, thank you. Thank you for that. Not quite, it's a tough question to answer in part because as you can see, based on what indicator you're looking at, they're all coming from a variety of different sources, some of which may have strong community or youth or consumer participation in that data collection process, and others that quite frankly may not. So I'd invite others, Beresford or others, to comment on that. But and then why don't we see if there's any better response to that question than I just gave first, and then I'll turn it over to Olga for her question.
I'm sorry, can you repeat the question?
Oh, so I think the comment that Kate, and by the way, nice to meet you and thanks for joining us, Kate. The question really was to what degree are families and consumers involved in collecting these data points currently, or how can we get families and consumers and youth more involved in collecting and looking at and participating in this data process?
And that is a great question. I was holding back on even introducing that. Family engagement, and as I refer to it, full employment in the process is everyone's responsibility. How we do it is a good question. And I think we have to continue to have dialogue. Data collection and data informed is very important to this whole process. And I want us to realize that involving the subjects of the data to help us define and tell us, what the antecedents to that data is and what it means to them. Because from our perspective, it's one thing. From the perspective of those who have lived experience in it, is another thing. And I'm not sure that representation from Mike Halpern and Maureen O'Neill and myself are enough. Of course, that's a concern because you asked a question of how that happens. It happens by us going out there and finding those individuals, identifying the places where they are, because you asked Sarah Egan asked a question about geographic and where the individuals are. Not only where those families are, those individuals that stand in the light of need are, but where are the services and how close are the services to them has everything to do with access and all those other barriers like transportation or those things we know. How we get more folks and identify more folks that have that lived experience, we look in the non-traditional places. I remember 20 years ago when we used to have these conversations, everyone would talk about those traditional places like the church, school, and what have you. Well, we have to broaden our aspect and have the ability to pivot, because a lot of those families find themselves, and those individuals, the subjects of this data and the primary benefactors of the work that we do find themselves, and sometimes we find them in those other systems that traditionally have not communicated with each other. Also in the community, in those non-traditional places, like those street corners, like those bars, like those cafes where people are drowning their sorrows in the depression that they find themselves in. So those non-traditional places, I mean, they're all around us. They exist in the atmosphere and the environment that we live in. And a lot of us, just like our panhandler in the intersections that we pass by every day, we ignore them, but that's where they are. And I don't know if that answers your question directly, Kate, but we can have further conversation on that coming from a parent's perspective.
Yeah, thank you, Beresford. Let's get Olga's question, and then I'm going to turn it back over to Beresford to wrap us up. Olga?
Well, hi. I wasn't really going to ask a question. I was going to talk about the cost aspects of the dashboard that we have in there. And I was just going to comment and say that the all payer claims data could be a source of information about costs, depending on the services that we're looking at and if it's covered by insurance, including the out-of-pocket cost to families.
Yeah, great point. And I think very consistent with us wanting to really think about these indicators, all of them really being across systems, across payers. And you're correct that the all payer claims database is a great source of information on cost across payers. Thank you for that. Okay, an hour goes by quickly, so it's 9:58. So let me turn it over to Beresford to wrap us up, and then we'll go from there. Thanks, everyone. Beresford?
Yeah, so a lot of my wrap up is in what I just said. I don't think I have to sell the importance of data and data collection and data aggregation to any of you all, and I'm glad to see so many of the data gurus and the data specialists like Sarah Becker at the table. And you know, Sarah is someone who I've been around and who has supported the work for the last 20 years. And when I see Sarah at the table, you know, I know that we have more folks that have been entrenched in this work for 20 years or more. What I'm interested in seeing, because just like I see Sarah around the table, there are parents and individuals and people that that you just identified and asked questions about, Kate, that have been around the table as long. I think we do ourselves a favor and a benefit, and do the system this work a benefit when we start encouraging those folks, those people that have skin in the game, to take on leadership positions. When we talk about engagement, that's one thing. When we talk about fully employing them in the process, I think this is where it begins. By collecting that data, involving the subjects of that data in the process, employing them in the process, like you employ a fork when you're eating or a pen when you're writing. I think that moves us further along the line. Because it is that old saying, and I'll get a little theological on you, physician, heal thyself. And as I get theological and reference scripture or anything like that, I want us to look and assess, do we have the right people around the table? And do we have enough of the right people around the table? And I think that's a poignant question that Kate shined a light on. Do we have enough of those individuals with skin in the game and lived experience around the table? And I think we all can answer that, because we seldom meet that elusive number of 51% parent involvement or folks in the game. We've come close, and I'd like to acknowledge the fact that we've come close in the recent years, and that's what makes this work more exciting. We have OPM represented here robustly, and I'm glad to see that, because speaking theologically, what we're attempting to do, we want to bring this and influence the General Assembly in our top legislators here. And I told Scott this a couple of days ago. When you look at the positioning and the authority of this stuff, we want to get this to a place where our General Assembly and our legislators and our governor embrace this. Looking at the governor as God Almighty and OPM as the Son of God, you know, nothing gets to God up except by the Son. But that doesn't say that OPM has the slick path or the easy path to acceptance, because even the Son was pinned to the cross and had to say, Allah, Allah, Lomo Sabachthani, that is to say, my God, why hast thou forsaken me? So this is a way to bring a passionate and influential group of individuals who are doing the work together, along with those who the work impacts and affects, whether positively or negatively, together and support one another to support our structures in our government and our decision-making process, but also not only to support it, but have a voice in it and be the influential piece. That's what this work is about. I think those are the things that we need to consider as far as next steps. You know, as I talked about what this process was going to look like today, there are some things that we have to make a decision on. What can we get done? What can we legitimately get done and thoroughly and effectively get done in the next 5 months? Is the best cadence to have monthly meetings? You know, and that would be scheduling 5 meetings, one every month, April, May, June, and July, and also counting this meeting. What can we actually get done? And who should we also bring to the table? Because I think each one of us would look around and look at the 21 participants that are on this call today and assess or measure, do we have the right folks around the table? So let's consider that. Let's have those conversations. Do not hesitate to reach out to Tim Marshall, Jeff, myself, Scott, or any one of us, or each other for that matter, and have those discussions and bring it back to the table and see where we are. This is work that is more important than I can explain. So with that, let's do it. Let's be charged, and let's recommit ourselves and put the legs back under this, because without the data that we are collecting, without us sharing that data with one another, it really stifles the work. Data requires us to ask more questions. So let's get used to rolling our sleeves up and being courageous enough to ask those hard questions. And there's no stupid question. There's no dumb question. There's no question that slows it down. Asking those questions, banging that data up against one another, especially coming from different systems, talking about one group of individuals or folks or a group of folks is the key to this. So with that, Jeff, I'll pass it back to you, and I'll give you the assignment, charge you with adjourning us.
Well, I certainly can't follow that. That was a tour de force, Beresford. So I'll just close out the meeting. Thank everybody once again, and we'll see you next time. Stay tuned for more from us. Thanks, everyone.
Thank you.
Bye-bye.
And the next meeting date is scheduled for April 27th, I believe.
Yeah, April 27th. Thank
All
you.
right.
Bye-bye.
See you then.